Dear Facebook Pure Urology viewers, good evening one and all. Today our topic is ultrasound guided obturator nerve block. As you all know, those who are doing TU or BT surgery, in this surgery, if the tumor is located on the lateral wall of the bladder wall, the obturator nerve is very close, and that causes jerk. That is because of the obturator muscle contraction, and this jerk can lead to sometimes deep vessel injury can also occur because external iliac vein, internal iliac vein may be close to the obturator nerve, especially if the loop is very thin and if the current is very high. This can happen. Various methods are there to reduce this by giving general anesthesia, deep anesthesia, muscle relaxants. All are actually partially effective. The current generated will be so high, the nerve, if contracts, the muscle also will contract. Nerve block, for which today our speaker is Dr. Soumya Vastrad from Hyderabad, who has done anesthesia DNB from Care Hospital. I will briefly answer the questions and then I will hand over the program to her. So today's topic is video based surgical presentation on ultrasound guided obturator nerve block by Dr. Soumya Vastrad. Currently she is working as senior consultant anesthetist at Srikara Hospital, Hyderabad. The Rangaraya Medical College she did diploma in anesthesia, and DNB she did in Bangalore Hospital, Bangalore. Pastly associated with many reputed hospitals as consultant anesthetist with more than 8 years of experience under Axon team. Presented paper in National Vascular Conference Visicon for 3 consecutive years. Best Paper Award 2010 AP State Conference Oral versus Intranasal Midazolam for a pre-medication in pediatric patients was her paper. Skills and key competencies: ultrasound guided nerve blocks, central line and PICC line insertions, pediatric regional anesthesia, all the general regional anesthesia and critical care skill. With this, madam, normally in urology, other than obturator nerve block, what other blocks you will give? Do you give block for brachial fistula and AV fistula in the wrist?
Yes, sir, we can give a block. You can give either a supraclavicular brachial plexus block or axillary brachial plexus block. So that will suffice, and the whole limb will be paralyzed, and you can easily do your brachial plexus and the AV fistulas. It is proven to be better doing it under block because the block effects leads to vasodilation of the vein. So both the vessels. So the anastomosis is much better as compared to when it is done without a block. So the chances of success rate under a block is more. Success rate.
Yes, madam. Madam, normally the nerve blocks are given based on the anatomical landmarks, particularly bone related parts previously, before the ultrasound has not come way in the utility of these blocks. Do you think that ultrasounded blocks are better than anatomical landmark based, because you can see internally where your needle is there like that? What is your opinion? Is the ultrasound made a difference in your nerve blocks and its success rate also?
Yes, sir, a lot of difference. Initially, like there are a lot of anatomical variations from person to person, but these landmark based techniques are based on bony landmark techniques. So we think it is there, the nerve is there, and we just give blindly. But how close we are giving the local anesthetic, how close we are injecting to the nerve, we are not sure of it. Sometimes it comes, sometimes it doesn't come. But wherein when we use ultrasound, we can see the nerve and the plexus from our own eyes, and we can go near it, give limited amount of local anesthetic. Whereas in the previous techniques, we had to give lot of amount of local anesthetic so that it pierces the fascia and reaches the nerve somehow and blocks it. But here, when we are sure, when we are able to see, when we can negotiate our needle to very near to the nerve, we can reduce the amount of local anesthetic we give.
Okay. In addition to that, do you do inguinal nerve block for any inguinal surgery as well as the as well as the scrotal surgery, do you routinely give?
Penile
Penile,
block for that
penile
certain
nerve blocks, do you do?
the hernia can be done, so hernia surgery,
Yeah.
inferior epigastric.
There also, can you identify the interiliac muscle and extrailiac muscle separately with ultrasound in given anesthesia? Because
Yes,
normally we surgeons give L1 level block, approximately predicting between interiliac and extrailiac, and usually that doesn't come well. Do
no,
you
sir,
think
we
that
can
these
do it
muscle
ultrasound
strengths
guided, sir. We can do it.
ultrasound?
We can find a facial plane separating both the muscles, and we can inject over there.
Okay. Coming to the today's topic, madam, related to the operator nerve block ultrasound guided. Normally, other than urology, does anybody give operator nerve block, madam?
Well, if we want to do some procedure in the inguinal area involving the skin over the adductor muscles, that is the medial part of the thigh, we need to give obturator nerve block, sir.
So other than orthopedic department, like that, they will be asking for you.
Vascular surgery we used to give because they used to do bypasses under blocks
Nerve
only,
block.
sir. No blocks.
Okay.
That time to cover the medial part of the thigh, we used to give anterior branch of the obturator nerve, we used to block.
That means
Along with
this is
other nerve.
atherosclerotic diseases bypass surgery, you mean to say?
Yes, sir. Very
Vascular blocks in the femoral and external femoral branches like that, if you want to
no
populate it to
popliteal
here.
bypasses and all. Okay.
Okay. So I think with this introduction, you please hand over the program and explain. You can take your time. This is very important. We always, as urologists, feel that it is difficult and where is the operator nerve? We don't know where is the how the instead of that we that also causes we depend on general anesthesia that also causes. But definitely, if you are using cautery, this type of anatomy will be very helpful for us. Please take over the program, madam. Thank you. You can share the screen. Yeah. Yeah, screen is shared. Thank you. Okay, madam, you can start. Hello.
Yeah. So
Yeah.
today, good evening, everyone. Today's topic is ultrasound guided obturator nerve block. Coming to the
You
history,
can keep your video on, madam. Video is not on. Your video is not on. You want to keep your video off?
No, sir, it's okay.
Yeah, please.
Thanks.
Yes, madam.
Coming to the history, Labat was the first one to describe the obturator nerve block technique based on surface landmarks in 1922. It was later modified by Parkes in 1967. In 1993, the interadductor approach was described by Wassef, further which was modified by Pinnock. In 1973, Alan Winnie was one who introduced the concept of 3-in-1 blocks. But now we are able to block obturator nerve by seeing it with the help of ultrasound.
Yes, madam.
Coming to the indications of the ultrasound guided nerve blocks, obturator nerve block is commonly performed to prevent thigh adduction during QRBT in urology, to prevent optimal analgesia for knee surgeries, to treat chronic hip pain, and to improve persistent hip adductor spasticity in cases with paraplegia, multiple sclerosis, or cerebral palsy patients. Coming to the contraindication, patient refusal, inguinal lymphadenopathy, perineal infection or hematoma or infection at the site of needle insertion are absolute contraindications. Pre-existing obturator neuropathy, clinically manifested by groin pain, pain on the posteromedial aspect of the thigh, and occasionally paresis of the adductor group of muscles are relative contraindications of this block. Obturator nerve block should be avoided in presence of coagulopathy. Complications, there are no reported complications as such, but obturator neuropathy secondary to needle trauma, intraneuronal injection, nerve ischemia, or local anesthetic toxicity are the possibilities. Accidental puncture of the obturator vessels could result in unintentional intravascular injection and hematoma formation. Anatomy, the obturator nerve arises from the anterior rami of second, third, and fourth lumbar nerves. It travels with the lumbosacral trunk in pelvis at the sacroiliac joint level, that is the L5 level, under common iliac artery and vein, and runs anterolateral to the ureter. At this level, it courses close to the wall of the bladder on its inferior lateral wall. It exits the pelvis through the obturator canal. It then divides into anterior and posterior branches. The anterior courses distally, lying between the adductor brevis and adductor longus muscle. The posterior division passes between adductor brevis and adductor magnus muscle. The anterior branch innervates the adductor brevis, longus, gracilis, and rarely pectineus muscle. The posterior branch supplies multiple branches to adductor magnus, brevis, and occasionally obturator externus and adductor longus. Posterior branches give articular branches to capsule of the knee joint. Articular branches to the hip joint come from the common obturator nerve. So these are the ultrasound picture showing the planes where we need to give the obturator nerve block. So this is the adductor longus, this is the adductor brevis muscle, and this is the adductor magnus. This is the pectineus muscle. So this white short arrow showing this plane here is where the anterior branch of the obturator nerve lies. And this yellow arrow shows the plane wherein the posterior branch of the obturator nerve lies. So obturator nerve block for TURBT surgery. During TURBT, when the irrigation fluid fills the bladder, it distends the bladder. At this time, the bladder wall comes in close contact with the obturator nerve. So when we use the electrically stimulated cautery to make cuts, due to the direct electrical stimulation of the nerve, there is contraction of the thigh muscle, and also which leads to sudden bladder contraction, causing bladder perforation, sometimes obturator artery perforation as well. Sudden thigh movements and bladder perforation were reported to occur in 40% and 5.7% of patients respectively during the TURBT surgery involving the lateral wall of the bladder in absence of obturator nerve block. A retrospective study comparing recurrence rates in patients with bladder tumor on lateral wall receiving TURBT with or without ONB demonstrated that ONB could prolong the mean time of recurrence of the bladder tumor by 7.8 months compared to 15 months with block. This finding suggests that ONB can facilitate complete resection of a tumor situated on the lateral wall of the bladder by immobilizing the surgical field. Preventing obturator jerks. It can be done by reducing the diathermy current, using bipolar diathermy, avoiding overfilling of the bladder, resecting the tumor in thinner slices, and by doing laser resection. The obturator nerve block, ultrasound guided, can be given by two approaches. The first one is the proximal approach, where the common obturator nerve is targeted. And the second one is the distal approach, where both the distal branches are blocked separately. So this is the ultrasound picture showing where we give the common obturator nerve block. So this is the pectineus muscle. This is the adductor longus. This is the adductor brevis, and this is the adductor magnus. And this is the obturator externus. So here is the plane between the pectineus muscle and the obturator externus. In this plane lies the common obturator nerve. So when we direct the needle and get the needle tip to lie here and inject around 5 to 7 ml of the local anesthetic, we can block the common obturator nerve.
Okay.
So this is the position of the patient for both the kinds of approaches, where the hip is in abduction and external rotation. This is the needle which is used. It's a 100 millimeter needle, Stimuplex needle. So this is a ultrasound image showing this is a pectineus, adductor longus, brevis, and magnus muscle. So we need to negotiate our needle to this area. This is a triangular space. So like this, if the needle comes in plane technique using a linear probe, and we need to inject 5 to 7 ml of local anesthetic drug. So we can use 0.25 to 0.375% of bupivacaine as a local anesthetic, which is sufficient. So 0.25 is a commercially available solution. To formulate 0.375% of local anesthetic solution, we need to mix equal amounts of 0.5% and 0.25% of the drug. So we'll end up getting 0.375% of bupivacaine. So here you can see the area being infiltrated with local anesthetic. So there is distension.
Madam, this obturator longus will be lateral to the extra femoral vessels, na?
So medial, sir. First we need to locate the femoral vessels, and then probe should be negotiated medially to see this anatomy.
Okay. So you should see artery, then vein, then come medially, then see the anatomy of obturator longus, brevis, and magnus. Between the longus and brevis, you are injecting the. Now you are going deeper.
Deeper, yeah. This is for the posterior branch, sir.
Yeah, posterior branch. Between the brevis and the magnus.
Magnus, yes.
Usually there will be always an echogenic line there.
Yes, sir. Usually it will be there because the facial.
Is it a septa or nerve, madam? Nerve also can be seen.
No, sir. Nerve cannot be seen because it is a very small nerve. We can see the plane. So both these are the plane blocks, sir. That is we need to give some more amount of drug. Usually, if you can see the nerve, 3 to 5 ml of drug is more than enough to block the nerve. But here we are not able to see the nerve. That is the reason we inject around 7 ml of the drug.
7 ml, 0.375, 37% bupivacaine.
This is another video showing the anterior division block. So you can see the needle clearly. Here, this anterior branch lies with the obturator vessels. So accidental puncture of the vessels is common in this blocks.
Procedure. Then you have to aspirate and then first confirm and then.
Always aspirate. When there is a negative aspiration, then only proceed and give the block.
Okay. Now you are going deep. No.
This is only the anterior. The one which I showed previously was both anterior and posterior.
Is it the nerve will be above the fascia or below the fascia like that?
In between the fascia, sir. Facial planes separating both the muscles.
Okay, okay.
That's it. Thank you, sir.
Is over, madam?
Yes, sir.
So thank you very much. And see, basically, how will you know that is there any stimulation method to know that the obturator nerve is blocked or not? No.
Not stimulation, sir. We can check the adductor muscle strength. We can ask the patient to adduct the.
He cannot do that.
Sir.
He cannot do that.
There will be weakness of adductor muscles.
So if the obturator nerve is blocked, there will be weakness in the adductor muscles.
Yeah. This has to be done before giving spinal, sir. After giving spinal, you cannot check. So if you want to check, be sure, then first give the block, check the effect of the block, and then give spinal and proceed with the surgery.
That is very important point. So obturator nerve block should be given when the patient is completely lower part is completely active, and then we can check the.
You want to check it, yes, sir.
You want to check it. Normally the needle size is 18, madam. 18. This needle
100 mm, sir. 10 centimeter needle.
10 centimeter is the length, and gauge will be how much it will be? 18 gauge.
I don't know, sir. Exactly 20 gauge, I think.
20 gauge maybe it will be. And usually you will give 7 ml local anesthesia. In both planes, 7 plus 7 you will give.
14, yes, sir. Total 14.
So that is safe point bupivacaine. By chance, if bupivacaine goes into the intravascular, something will happen?
Yes, sir. Local anesthetic toxicity will come.
That can come. Yeah. The ECG abnormalities can come.
ECG abnormalities. Patient might have. Patient might throw seizures. Patient might go have arrhythmias.
Yeah, yeah. Because this is a drug which acts on the
Yeah, it's
which
very
acts on
cardiotoxic, sir.
the cardiac toxic drug, bupivacaine.
Yes,
And this effect will be there how much time, madam, normally?
so usually it should be there for 12 to 18 hours, sir.
12 hours.
Yeah,
So
it
will
should
the
be there.
patient will have any walking difficulty with this block?
No, sir, it shouldn't be there actually. But with this local anesthetic, when we give it only 7 ml, it won't last that long.
So after this spinal anesthesia, there will be some
Minutes
weakness
of
for a day.
usually they won't have any problem walking, sir. After that,
Okay.
we can walk. Yeah.
Okay. Have you given any time bilateral uptrator nerve block, madam?
Not yet, sir. Not till
Not
now.
yet. Generally, one side tumor, you will do this thing. Because bilateral uptrator nerve block may cause some problem in the walking
No,
because
sir. Nothing of that sort. Like it is not anywhere in the literature.
that walking will be affected.
Might be, sir. Walking adductor muscles won't hamper, no, sir. I don't think so. It should be in
It
this.
should be. Okay. So other muscles will compensate and it's reported that walking will not be a problem after the uptrator nerve block. Okay. So in case if the block doesn't come in one go, can we repeat again after some time? Within
Yes, sir.
half hour, we
You
can
can.
repeat.
Yes, sir.
So without ultrasound, do you recommend this type of procedure should be done? No. We cannot identify any plane. So it's not possible to see adductor longus, magnus brevis by depth perception. We may not be able to.
Yes, sir.
Yeah. Okay, madam.
Complication rates increase, sir. With this.
Yeah, yeah. So thank you very much, madam, for your presentation. Even though it is a brief presentation, very valuable. Actually, I have seen this first video in my hospital. Dr. Soumya Vastrad, being the wife of Dr. Siddhalinga Swami, our consultant urologist, we have called and we are now planning to implement this procedure. On that day, we could see that all muscles could be seen and all injection could be seen, planes are could be seen. So even though three-dimensionally it is difficult to represent in this video, and we may do one live program also in future, so that it looked very simple for me and the patient got benefited. So let's hope in the future we will do a live session where you will be practically working in three-dimensionally how you go needle, then it will understand. Here only thing we are not able to see the femoral vein and femoral artery, so majority of the surgeons may not understand. If possible, we will do a live program, madam, in future. Yes, thank you very much, madam. Let us conclude the session. Thank you.